Most people over 65 believe that more medical testing always means better health outcomes. They get every scan, every screening, every blood panel their doctor suggests, and they feel responsible for doing so. But there is a growing body of clinical evidence showing that certain routine tests that are genuinely useful at younger ages, can cause more harm than good after 65. Not because the tests are bad, but because of what happens after a result comes back, and what that result actually means for an older body. Today, I'm going to walk you through 5 medical checkups that most doctors would reconsider, or skip entirely, after the age of 65. This is not about avoiding healthcare. This is about understanding the difference between tests that save lives and tests that lead to procedures, anxiety, and harm without improving outcomes. This conversation could be one of the most important ones you have before your next annual physical. My name is Dr. Elizabeth Kavaler. I am a board-certified urologist and urogynecologist with over 20 years of clinical practice. My patients are predominantly in their 50s, 60s, and 70s, and conversations about which tests to get and which to question come up in my clinic constantly. What I am sharing today is grounded in guidance from the U.S. Preventive Services Task Force, the American Geriatric Society, the American Cancer Society, and published clinical research on the concept of overdiagnosis and overtreatment in older adults. The goal is not to scare you away from your doctor. The goal is to help you walk into your next appointment as an informed patient who knows which questions to ask. Before we get into the 5 tests, I want to explain a concept that most patients never hear about. It is called overdiagnosis. Overdiagnosis happens when a screening test detects a condition that would never have caused symptoms, harm, or death during the patient's lifetime. The condition is real, the finding is real, but treating it provides no benefit and often causes significant harm through surgery, radiation, medication side effects, and psychological distress. This is not a fringe idea. The New England Journal of Medicine has published extensively on overdiagnosis in cancer screening. The British Medical Journal has called it one of the most underappreciated problems in modern medicine. The risk of overdiagnosis increases significantly with age because older adults have more competing health conditions, shorter life expectancy windows, and less physiological reserve to tolerate aggressive treatment. The balance between benefit and harm from many screening tests shifts in a fundamentally different direction after 65. With that context, here are the 5 tests that many leading medical organizations now recommend reconsidering after 65. The first test is PSA screening for prostate cancer in men over 70. The PSA test measures prostate-specific antigen in the blood. An elevated result prompts biopsy, and a biopsy that finds cancer leads to treatment. That chain sounds logical, but the clinical evidence tells a more complicated story. Prostate cancer is extremely common in older men and extremely slow-growing in most cases. Studies consistently show that the majority of men over 70 who die with prostate cancer do not die from it. They die from something else, with prostate cancer present but never causing problems. The U.S. Preventive Services Task Force currently recommends against routine PSA screening in men over 70 precisely because the harms, including incontinence, erectile dysfunction, and complications from biopsy and surgery, frequently outweigh the benefits in this age group. This does not mean men over 70 with urinary symptoms or a concerning history should avoid evaluation. It means that routine annual PSA screening in an otherwise healthy older man without symptoms often leads to treatments for a cancer that would never have harmed him. That is overdiagnosis in its clearest form. If you are over 65 and your doctor raises PSA testing, have an honest conversation about your individual risk, your life expectancy, and what you would realistically do with a positive result. That conversation matters more than the test itself. The second test is cervical cancer screening, Pap smears and HPV testing, in women over 65 who have had adequate prior screening. Cervical cancer is caused by the human papillomavirus. It develops slowly over many years. Women who have had regular Pap smears throughout their adult lives and have had consistently normal results have an extremely low risk of developing cervical cancer after 65. The American Cancer Society, the American College of Obstetricians and Gynecologists, and the U.S. Preventive Services Task Force all agree on this. Women over 65 who have had 3 consecutive normal Pap smears within the past 10 years, or 2 consecutive normal HPV and Pap co-tests, should stop routine cervical screening. The risk of finding a meaningful cancer is extremely low, and false positives lead to unnecessary colposcopies, biopsies, and anxiety. The important exception is women who have not had regular screening earlier in life, women who are immunocompromised, or women with a history of cervical cancer or significant abnormalities. These women should continue to be evaluated. If you are over 65 and have always had normal results from regular screening, your gynecologist may well tell you that you do not need another Pap smear. That is not them being dismissive. That is evidence-based medicine. The third test is routine colorectal cancer screening after age 75 to 85, depending on individual health status. Colonoscopy is genuinely one of the most effective cancer screening tools ever developed for adults between 45 and 75. It saves lives in that age group. The question is, what happens to the risk-benefit calculation after 75? The U.S. Preventive Services Task Force recommends that colorectal cancer screening decisions in adults aged 76 to 85 be individualized based on patient health, preferences, and prior screening history. For adults over 85, routine screening is not recommended. Here is why. Colorectal cancer takes 10 to 15 years to develop from a precancerous polyp into a life-threatening malignancy. If a polyp is found in a 78-year-old with significant heart disease, diabetes, or other serious conditions, the risk of the colonoscopy procedure itself, including perforation, bleeding, and anesthesia complications, may equal or exceed the lifetime benefit of finding and removing that polyp. This is an individualized decision. A fit, healthy 77-year-old with no prior colonoscopy is in a very different clinical position than a frail 77-year-old who has had normal colonoscopies throughout their 50s and 60s. The point is that age 75 is the moment when this conversation should actively happen between you and your doctor, rather than simply continuing the same screening schedule you had at 55. The fourth test is annual full-body CT scanning, which has become increasingly popular as a concierge wellness offering. The appeal is understandable. A whole-body scan promises to detect everything that might be wrong before symptoms appear. It sounds like the ultimate form of preventive healthcare. The clinical reality is different. Full-body CT scans expose patients to a meaningful dose of ionizing radiation, roughly equivalent to 70 chest X-rays in a single scan. For a 65 or 70-year-old, that radiation exposure itself carries a small but real increased cancer risk over the subsequent decade. More significantly, full-body scans almost always produce incidental findings: small nodules on the lungs, spots on the liver, cysts on the kidneys. The vast majority of these findings are completely benign, but each one triggers a cascade of follow-up imaging, specialist referrals, and sometimes biopsies to rule out cancer. Studies published in JAMA Internal Medicine found that the majority of incidental findings from whole-body CT scans in asymptomatic adults led to further testing, with very few ultimately revealing a clinically significant condition. The result for many patients is months of anxiety, additional radiation exposure from follow-up imaging, and in some cases, invasive procedures to investigate something that was never a threat. No major medical organization, not the American College of Radiology, not the U.S. Preventive Services Task Force, not the American Medical Association, recommends routine full-body CT scanning as a preventive health measure. If you are paying out of pocket for annual whole-body scans, the money and the radiation are very likely doing you more harm than good. The fifth area is not a single test, but a pattern that affects millions of older adults. Aggressive blood sugar management and intensive HbA1c target setting in people over 75. HbA1c is the standard blood test that measures average blood glucose control over 3 months. It is a genuinely useful test. The issue is not the test itself, but what gets done with the results in older patients. Current guidelines from the American Geriatric Society are explicit on this point. For older adults over 75, especially those with multiple health conditions, a relaxed HbA1c target of 8 to 8.5% is often more appropriate than the under 7 target recommended for younger diabetic adults. The reason is hypoglycemia. When older adults are pushed to maintain very tight blood sugar control through aggressive medication, They are at high risk of blood sugar dropping too low. In a younger adult, hypoglycemia causes shakiness and discomfort. In a 76-year-old, it can cause a fall, a fracture, a cardiac arrhythmia, or a loss of consciousness. Multiple large studies, including the Accord trial, found that intensive blood sugar control in older diabetic adults increased mortality rather than reducing it. More aggressive treatment produced worse outcomes. If you are over 70 and your doctor is pushing hard to get your HbA1c below 7% through multiple medications, it is entirely appropriate to ask whether a relaxed target might be safer for your age and individual health picture. That conversation could protect you from the very harm the treatment is meant to prevent. I want to be clear about what this video is not saying. It is not saying stop seeing your doctor. It is not saying refuse all testing. It is saying that after 65, the right tests for you are increasingly individual rather than universal. The most valuable thing you can do at your next annual physical is ask 3 questions. First, what is the purpose of this test? Second, what will we do differently if the result comes back positive? Third, what are the risks of following up on an abnormal result? If your doctor cannot answer those questions clearly, or if the honest answer to question 2 is that you would not change your management regardless of the result, then the test may not be worth doing. The tests that remain genuinely valuable after 65 include blood pressure monitoring, cholesterol management, eye exams for glaucoma and macular degeneration, hearing assessments, fall risk evaluation, and cognitive screening. These are tests where early detection leads to clear interventions that improve quality of life and reduce serious harm. The goal after 65 is not to detect every possible abnormality. The goal is to maintain function, quality of life, and independence for as long as possible. Sometimes that means doing less, more thoughtfully. You have spent your entire life trusting the medical system to tell you what to do, and for the most part, that trust has served you well. But after 65, the most important skill you can develop is knowing how to participate in your own healthcare decisions, rather than simply receiving them. That means asking questions. That means understanding the difference between a test that helps you and a test that simply finds things. The 5 areas I covered today are not reasons to fear your doctor. They are starting points for a better conversation. You deserve care that is designed around your actual life, your actual values, and your actual goals, not a one-size-fits-all screening schedule that was designed for a 45-year-old. I am Dr. Elizabeth Kavaler. Thank you for watching. I will see you in the next video.